Thank you so much, ma'am. We'll now move on to the next session. This is an academic session, which is on AI in cardio-oncology, and it gives me great pleasure to introduce our chairperson, Dr. Bharat Bhosle, Senior Consultant Medical Oncologist, and also the founder director at BB Precision Oncocare, Mumbai. Over to you, sir.
So thank you, Kashish. So as we bring into AI session, it is no more a theoretical thing, it's a reality. And our next session is dedicated for that. But we have to remember the patient safety is the priority and our goals to use these tools in a validated, transparent and supportive manner. So our speaker will start, everybody knows her, so I will not. So you can utilize this minute also.
Yeah, thank you, Vivek, for this opportunity. And even though it was last moment, I was asked to present this just 3 days back. And I used a lot of AI to help me prepare this presentation. So what is AI? We've been hearing about AI since like a long time. And I am a breast surgeon. I'm neither a cardiologist nor a medical oncologist. So a misfit in this group. So I'll be talking like a surgeon today. AI is basically telling the machine that think like human beings. Think of all the cognitive function that humans will do. And machine learning is a small subset of artificial intelligence where we are asking the machine that you have to perform these tasks without specifying or giving explicit instructions or any patterns by just giving them a set of data and asking them to learn it. So if we look at Wikipedia, surgeons look at Wikipedia, sorry. So machine learning is a field of study in artificial intelligence concerned with development and study of statistical algorithms that can learn from data and generalize to unseen data and thus perform tasks without explicit instruction. So that is what is machine learning. Today I'll be presenting 2 papers where AI is used to develop predictive models for patients of breast cancer and predicting cardiotoxicity in them. There are 2 very different papers. One is predicting late toxicity. That means that a patient who has already survived 5 years, what is the chance of cardiotoxicity in the next 10 years? And the second one is predicting early toxicity. So this is my first paper, the Korean deep serve model. And I had to go through a lot of YouTube videos to understand a lot of terminologies in AI, and I will tell you what I learned. So the question answered here is, what is the risk of toxicity in my patient who has already survived 5 years over the next decade? So what they did is, the Koreans, they took 5,131 women, a retrospective cohort, from the Korean National Insurance Service data, and they split the cohort into 4:1. The 4 was the derivation cohort, 1 was the validation, and they developed a deep learning survivor model called a deep serve based on machine learning. And then they compared this model to traditional models like Cox proportional hazard or random forest. I'll come to what these are. And they assessed by time-dependent concordant index. Now, C index or concordant index is again a very important term when you're assessing predictive models. I'll tell you what is that. And they also did sharp additive explanation analysis on it. Again, I'll come to that. So what is CTD index? CTD index is a metric which is used in survival analysis to evaluate how well the predictive model is ranking individuals based on their risk for the event to happen over time. So it's a dynamic thing because your risk is changing over time, so it is also predicting dynamically. A value of 0.5 means the model is no good. It's like a random coin flip. A value of 1 means the model is perfect in predicting the accuracy. So let's go ahead. So what did this study do? They fed identical sets of around 18 clinically relevant factors like socio-demographics, lifestyle, lab tests, comorbidities, and the unique thing was it's a combination of cardiovascular risk and cancer-related risks. That means the treatment given, anthracycline, AI, and then they fed it into 3 survival models: Cox proportional hazard models, random survival forest, and deep serve. So how many of you know what is random forest algorithm? Raise your hands. Not many. So we're all in the same boat, except I expect you to know. So a random forest algorithm is basically like a decision tree. So they ask questions. Does the patient have diabetes? Yes, no. Hypertension? Yes, no. And based on those decision model, come to a final predictive that yes, there is a risk of cardiotoxicity or not. So now imagine thousands of such decision trees, because we are talking about AI. So thousands of trees clubbed together with various permutation combinations and then giving a final prediction that will be way more accurate. So that is what random forest survival model is. What is deep serve? The deep serve was based on deep neural network. It is a very complex non-linear interaction. It was based on Cox regression, but is way more complex. So you see, these are the inputs and this is the output layer. So a lot of complex interactions happening here. And finally, what was the result? The C index that we are trying to look at. C index is telling us how accurate the model is. So deep serve was just slightly better. So the authors also looked at something more. Okay, we know that the models are equal, but what else is our model telling us? So here we come to something which is known as SHAP analysis. Again, very important in AI. SHAP analysis is basically telling us that this model is not a blind box. It's not like you're putting inputs, getting an output. It is telling us an entire pattern of why this output came, which value has what weightage, what predictability. And so we are able to tell that what are the exact risk factors which led to the predicted outcome. So what was the risk factors in this study? Age, history of stroke, dyslipidemia, anthracycline use, and AI therapy. And why is this so unique? Because it's a hybrid. It's a hybrid of conventional cardiovascular risk factors and cancer therapy iatrogenicity. So this was a unique study in that way that it combined both of them. And we can say that this was the stage for more accurate long-term models, long-term survival programs. Of course, there are limitations. There was no prospective external validation. It was an outdated data, so the trastuzumab usage was much lesser. And it was a retrospective data, so there were data gaps. So now coming to my second paper. So this was a study from Taiwan where they predicted early onset cardiotoxicity, that is within 1 year of treatment. This was published in the Breast this year only. And again, this was a retrospective cohort based on electronic hospital records. 1285 female breast patients from Taipei Medical University were included, and they looked at the 6 outcome cardiac events. So that was arrhythmia, MI, conduction disorder, coronary artery disorder, heart failure, and stroke. The problem was there was only 36 events. To circumvent this, what they did is they did a competition between 8 different AI models, from the basics like logistic regression to the most complicated voting classifier. And they found that the voting classifier showed the best performance. It had a AUC of 0.71 compared to the basic logistic regression, which was only 0.57. This is voting classifier. And again, it tells us that predicting cardiotoxicity is a very complex, non-linear problem. Simple regression model will not work on it. And with this model, there was some meaningful improvement in traditional baseline model. Again, SHAP analysis was done. And what was found that in this study, the important features were all pre-existing subclinical dysfunctions in the patient, rather than cumulative iatrogenic damage done by cancer treatment. So again, it had limitation like a retrospective study, limited validation, small events, and so on. So what is the future that we are looking at? The future that we are looking at is that we need to do more prospective validation. We need to have more real-world data in this so that it can be more globalized. And probably we're looking at models which can be incorporated into the hospital electronic record. There can be an automated risk alerts, and cardio-oncology referrals can be triggered on its own. So there can be an AI loop which can do prediction, it can raise alerts, and it can help us to take interventions. So that's all. Thank you.
Thank you, Dr. Neha. So machines have made our life easy but totally dependent, that mobile phone can describe. And the next session, we can discuss the questions. I would like to invite Dr. Purvish Parikh. It doesn't require any introduction. Sir will moderate a session on the same topic. I would like to call upon the panelist. Deepak is not there, so Deepak is going to join by AI, machine algorithm? Dr. Aparna madam?
I thought I'll join in person because
Yeah, Deepak, where are you?
I'm basically at my place.
Good to hear you. Dr. Aruni Ghosh and Dr. Neha. Sir is I think, appropriate and wonderful speaker for this topic.
After Neha's talk, now I'm a little confused here. What do I know about artificial intelligence? So let me start by something that you might already know. This is a book called The Pale Blue Dot. How many have read this book? Raise your hand. Okay. Do you know the guy, the author, Carl Sagan? So in 1977, this equipment called Voyager was sent by Earth to leave our solar system. And after it was several thousands of miles away, on 14th February, he asked NASA to turn the satellite to face Earth and take a photograph. And that blue dot that you can see right there is Earth in the middle of the solar system. Now this Voyager, after 50 plus years, is one light day away from India or from the Earth. That is 25 billion miles away. Okay. So now based on this, we'll take the perspective. And my first question to the audience is, how many of you have brought your computers here? Please raise your hand. So I think there are at least 5 or 6 people who understand my question. And for those who did not understand my question, this smartphone in your pocket is a computer, right? You can also make phone calls with it, but that is your computer. And what is relevant to that smartphone and this? Our smartphone today has a computer that is 25 times more powerful than the computer on Voyager 1 and 2. So that is the power that we have in our pocket. So now I'll come to the panelist. Neha has already mentioned that, but I want to know your opinion. What really is artificial intelligence? And Aruni, may I start with you, please?
Difficult question. So, when it came from Alan Turing's perspective and about artificial intelligence was to sort of mimic the human brain and sort of generate intelligence that would sort of be as close to a human brain, to be honest with you, which is why you come to the concept of all these convoluted neural networks, ANNs, CNNs, and then the subject of machine learning and deep learning, just to sort of mimic your neural networks, to be honest, with the same intelligence that of the brain, which then led to 2 subsets. One, language, from where large language models came into being, and one, predictive AI, where CNNs and ANNs came into being. So yeah, some predictive function, some reasoning function.
Right. And Neha, you mentioned that artificial intelligence is supposed to mimic the human brain.
Not mimic, but do the tasks.
Do the task.
Which,
So do you think that artificial intelligence is doing the task of the human brain as well as humans, or less than humans, or better than humans?
So it depends what the task is.
Okay, let's say we are talking about playing chess. Is Gary Fisher or Bobby Kasparov better than the computer?
I think at this point of time, we do have chess players who've been beating computers consistently. So AI still has to catch up.
How many of you agree with that statement? So actually, the IBM computer beat Gary Kasparov more than 30 years ago. But that is, chess is like 0 and 1, right? Computer language is binary, 0 and 1. Chess has only fixed rules. You can't change anything. So is there a computer program or artificial intelligence can be better than 0 and 1 as compared to human beings? For instance, bluffing. We are known to bluff all the time, right? So do you think that artificial intelligence allows the computer to bluff? Yeah, who has answered? Can you explain that statement? So there was a world championship of poker. And in poker, you know that you have to bluff, right? And there also the computer beat the smartest poker team of the world. So that is different things. Neha, you also mentioned machine learning, right? So this is a cartoon of machine learning and it explains exactly what you had said. Do you agree with that or not?
So this is input, feature extraction, classification, output. Yes. Machine learning has usually two parts. One where it is doing what it's asked to, other where it does without being specified. So yes.
So the classification is without being specified and the feature extraction is where it is doing, right? And then how is it different from deep learning? Which is below, right? The human doesn't exist in the lower part. How is it possible?
So the deep learning model, I believe, was created after the feature extraction. So it has already learned and now it's applying.
Right. But you understand what it is. So in my opinion, deep learning means that humans are absolutely unaware of what is happening. How the computer is functioning, what is the algorithm, what is the tree, how it makes a decision, we don't know. We have to take it for granted. And then when we take it for granted, then something goes wrong and I'll show that to you a little later. So I like to compare artificial intelligence and what exists on the internet with our program called Oncology Beyond the Obvious. And Amish has seen this slide as well. We do that on the second Tuesday of every month from 7 p.m. onwards. And you can divide the internet into surface web, deep web and dark web. So may I ask Dr. Aparna, do you think that you are familiar with all these webs or you access only a little bit or what is it?
Little bit. I mean, the surface web, definitely all of us use it all the time. Deep web to quite an extent because we all look at research papers when we are either looking for information or want additional information or even for medical records which we use in clinical trials. But dark web, I am not familiar with.
Right, right. So anybody knows any experience with dark web? Bharato is supposed to be.
I don't think
Anybody has accessed the dark web?
Nope.
Okay.
That comes with the invitation only.
So I took the advice of some seniors and used some tools to enter the dark web. And I could see that my passwords already existed on the dark web. Okay. So if somebody wants to hack my bank account, they need the following information: name, email address, phone number, password, date of birth and address, right? Then they can impersonate me and make a digital twin that can create havoc for my life. So on the dark web, these are the areas where my information is available. And you can see Yatra there, October 2nd, 2017. Since 2017, Yatra has some of my information. And you can see I have given the numbers 1 to 6, those are the numbers. So if somebody enters the dark web and starts searching for how to screw Dr. Purvesh Parekh, they can get all the information that is possible. And then they can use it. So how is this relevant to us? Technology, right? Artificial intelligence is technology and technology is responsible for 65% of all the advances. So Aruni, what do you think is your future, not only in cardio-oncology, but in healthcare in general, as far as technology is concerned, and with special reference to artificial intelligence?
I think the problem with most models today is they're single modality models. And people call models to be multimodal AI. Well, you've got to realize that you take images, which are single modality, like histopathology images, and take one radiology text and call it multimodal. Well, you need to have 360 visual impression in order to be real multimodal AI, in order to increase your predictive power. And I think where technology is heading towards is the analysis of that big data. We've got big data, but we can't harness it because we don't store the big data. And if you need to action big data, you need to follow up and you need to do surveillance. So technology in cardio-oncology, in cancer survivorship, data storage, big data, that's how your AI models, and it would take a lot of supercompute as well. So yeah.
So you think the technology of artificial intelligence will make your life easier or more difficult?
Depends on how you use it. So it wouldn't be a replacement tool, but it would be an assistive tool and augment your clinical decision making. Like, let's say, for example, response prediction, toxicity prediction. Again, you need to have those multimodal features to be precise. And that's something which multivariate analysis wouldn't get you.
Okay. But if we take a step back, do you think artificial intelligence is going to lead to loss of livelihood for people?
Jobs will be rechannelized, redirected. I don't think jobs will be taken away.
And if you want to succeed more in the environment of artificial intelligence, for instance, LinkedIn requires your capacity to use artificial intelligence tools to be more, to have a better chance of getting a good job. How will you prepare yourself for the future?
Interesting when you say that. Actually, artificial intelligence has increased an avenue for clinician jobs. On LinkedIn, if you go, you'll find a lot of job postings called clinical trainers. Or prompt engineers is another version of engineers. So clinical trainers is another version of clinical validators for how these AI models actually function. So you can see the redirection already taking place. So I'm not certain that it'll take up jobs. It's going to increase your jobs to make clinicians' life easier.
Okay. Neha, Aruni mentioned prompt engineering. What do you understand by prompt engineering? Till a few years ago, I didn't know that something like this existed, and suddenly now we have certificate courses of 2 years training for just becoming a prompt engineer. It's crazy, right?
Okay, prompt engineering, I think now I know. It's like you learn what prompts you put in the AI tool to get the result that you want.
Right, right.
I remember doing one small course for that.
Okay. So now let's come to application of AI exists in all the three spheres as far as we are concerned: service, education, and research. So, Dr. Aparna, can I start with research? Where have you been a part of, you've been a senior member of a international CRO? Where else did you use on a day-to-day basis AI in research?
Well, we haven't used it as much, but it definitely helps in drug development, and it also helps in reducing the timelines for drug development. Based on the analysis of data available, you can identify potential drug molecules that would be efficacious and at the same time safe based on the ADR. And in an important way, it would also help in identifying potential subjects that could participate in clinical trials, as well as selecting the right sites. So it would also help in that sense, and even to a great extent in data quality. But currently, in terms of the cost and the infrastructure and expertise, we're still behind in terms of using AI.
Right. Neha, you said that you gave the talk as a surgeon. So as a surgeon, do you ever use any AI tool in your day-to-day practice while you are at the hospital?
So, of course, I think if we really understand what AI is, then we are surrounded by it. And every day we are using so many risk predictive models which are based on AI. Even so many, so if we talk about robotic breast surgery, that has some components which has AI. And I think we are using AI on a daily basis, I guess.
Right. Aruni?
Well, I co-founded OncoFlow, where you have research and service. So you've got a mixture of LLMs, data extracting from the vast electronic health record systems, which you would take, doctors are part report searchers, so they would do the report searching for you and get to your targeted data points. So that's good for, collaborative research work. For service, it feeds that into your tumor board or your cancer MDT meetings, and then matches it to, sorry, I'm not promoting my company, but it sort of matches it to your treatment guidance. And as Aparna said, that, it's very good for clinical
We
trial
won't
matching.
charge you. You can promote your company.
And it does do clinical trial screening as well. So research and service, there you go. And for predictive AI, that's what I don't do. But for predictive AI, it gives you sort of, drug responses, drug toxicity predictions if you use that multimodal data well.
Vivek?
So, sir, even for planning the agenda of this conference, I had used AI to suggest me what are the important publications that I need to discuss.
Right.
But even after that, sir, I had to go to other journals in order to identify some of the publications which the AI had missed. Now, what my interpretation is that it was probably my inefficiency in putting the correct prompts to the AI that could, even identify that. But probably, a better education in AI could have made my task easier, and that is something that I think everybody should look on to.
What AI tool did you use?
So I used Gemini.
Only one tool,
Yeah,
right?
Gemini. I think Gemini has a deep research, module also. So I used the deep research one for Gemini, but I didn't use multiple other models because it was too consuming and it was too overwhelming for me.
Amish, before you start, can I ask Vivek one more question? What prompt did you use?
So of course, sir, I used a longer prompt like what are the best publications in this field.
I'll tell you just off the cuff. Before using the prompt, you should put the AI tool at a high pedestal. Yeah. For instance, if I'm looking for somebody who will guide me on breast cancer, I'll say, tell the AI, imagine that you are professor of surgery at Harvard Medical School. You have 30 years of experience. You have taught so many generations of students. And now I'm a student appearing for the exam, and you have to give me the answer. So you prepare the scheme of the AI in that sense and then start asking the prompt, then you'll get a better answer.
Okay.
This is my personal experience. Amish.
So just extending on to what Dr. Vivek said, last 6 months, either ChatGPT or Perplexity with Meta AI, I take their help in making PPT. But when I make PPT of my own, I feel they are not even at 60%. And you had taught me once at the airport, so prompts I have been doing more and more refined. Somehow I'm not reaching the level what we make. Probably it's a human touch, but I wanted to ask your opinion. Am I still not deep enough, or I want to believe that still AI is not where we are?
No, it is very simple. The answer is very simple. There is nothing called free lunch. Okay. When you are using a free or a pro ChatGPT program, you don't have access to the actual capabilities of AI. There are companies that are paying hundreds of thousands of dollars every month to get access to AI. And those are the companies which will get the full thing. Then when that PowerPoint slide comes and you can use them, then everybody in the audience will be awed. So it is, our limitation is how much we are able to access the capabilities of AI. I'm talking about hundreds of thousands of dollars. Like the big four, Accenture, Deloitte, when they make payments, their whole presentation, 2,000-page presentation can be made by AI. And Accenture was fined millions of dollars because they use that sort of presentation instead of actually using their brains. So that is the difference that we have.
Sir, one comment,
Yeah.
sir, about using AI to make PPTs, and I have tried both. I have made PPTs with AI, and I've ended up not using it and then rewriting the whole thing myself because it is never satisfying. And then when you're actually standing and talking, then it just feels so artificial that you're not able to connect with the audience.
Right.
So just a
Absolutely
comment on
right.
that.
Absolutely right. That is why so far we are still surviving. So, Aruni, you said that tools are to be used, but I feel that instead of calling them just tools, we have to make them our partners. What do you think?
Co-pilots, rather.
Co-pilots, right? Absolutely. Okay. So now coming back to, and this is a publication recently of AI applications in cardio-oncology care. And I don't want any of you to go through the list, but I'm just showing this to you to make you understand that a lot of people have done extensive work in this field. Now you might have read this article, Aruni.
Thank you so much.
So let's start with you. What do you think? What are you trying to convey in this article of yours?
So, cardiac MRI is it cost effective? Is it a feasible contextual resource in resource constrained settings? So what we were trying to highlight with that article is how can we advocate for precision cardio-oncology in terms of imaging? How can we get precise images? How can we provide capacity building, so government levels, national levels, so provide capacity building, training and education, and also use AI in sort of in places where you don't have reporting. How can AI assist in reporting cardiac MRIs, to be honest with you? So the popularization or advocacy behind CMR, which is gold standard for in ESC guidance.
Excellent. Our chairman for this session made a mention of this in the morning, and so I thought that let me elaborate. If we start using AI to report on MRI, then there's a big hue and cry in our country. And that is what happened. This was reported yesterday, but let's forget it. What about satisfaction? If we use, Bharat, please go ahead.
Deepak is one of the panelists attending virtually, so I would request Deepak also to
Right,
give his.
right. Deepak, can you hear me?
Yes, sir.
Okay. I apologize, I just forgot that you were online in this panel discussion. Please
Don't worry, sir.
let me have your
Pretty
comments.
interesting.
Please let me have your comments on AI as you think is important in your day-to-day real-world practice.
So we already use AI.
No,
There
so
is-
what? Just explain for the audience how it is used.
Let me put it this way. As a cardiologist, it is very common for me to find an ECG which is not read properly.
Right.
Am I really going to be able to teach people the ability to read a great ECG? And how many people am I going to be able to teach that to? Instead of me fidgeting around and having a ton of sessions trying to explain the nuances of some weird line on a piece of graph paper somewhere, what if I could actually help you with the outcome? What if I could actually help you treat the patient himself or herself? Rather than trying to say that no, you have to go to, at least for diagnosis purposes, to a very high-end hospital way far away in a place called Bangalore with its horrible traffic, cross the whole city, reach Narayana and then get diagnosed. And all the time the patient having the anxiety that what do I have? Why has my doctor referred me to such a place? So if we are able to use the input tools for AI algorithms, we are managing to keep it safe, simple, easily available, scalable, at least for the purposes of screening at this point in time in daily workflow. AI has the ability to democratize diagnosis.
All right.
And sometimes the diagnosis is all that we kind of want to think about. Yes, it requires validation so that we don't give the wrong diagnosis to people who don't know how to differentiate between two things. But that is the responsibility of people who are making the tool and the doctors who are involved in the dispersal of it. But for the common man, for the guy who's passed out of MBBS sitting in a rural hospital, who's having an ECG that looks all squiggly, Making the diagnosis of atrial fibrillation makes him a hero overnight in the village that he is in. For the doctor, for the patient who has come to him saying that I know this guy from childhood and now he's become a doctor, he will treat me. Well, that's very, very heartening, right? So that's where we do it. That's where we focus. And that's where I think the diagnostic capabilities of AI are important. Human oversight, human in the loop remains a critical component of it, especially when the human is an expert. So what it allows us to do, sir, is be able to record or at least report on 20,000 ECGs a day instead of reporting on 1,000 ECGs a day.
Perfect.
So the rare person who is there, that becomes not so rare.
Perfect. Thank you very much. Now, Aruni, I'm going to ask you, because we are run out of time, I have only one question for you. Can I have the slides? If you look at artificial intelligence and colorectal cancer, and this search was done last month, there are more than 300,000 references in PubMed, and in fact, 118 are from India itself. Okay. On the other hand, if you look at artificial intelligence and cardio-oncology, the publications are few, and there have been only 7 publications this year so far, and none from India. So if you want us Indian audience to understand what we should do in applying artificial intelligence to cardio-oncology, what is the message that you want to give to us?
So, artificial intelligence is a baby, and a baby needs food. We need to get that food. We need to create that data. We need to store that data. We need to have follow-up data. If you want predictive, so if you want 5 years follow-up predictive data, you've got to give it 5 years data. It can't magically create outcomes of 10 years and late effect toxicity. So garbage in and garbage out. Artificial intelligence is as good as the data you feed in. So that means, do you feed it the perfect data? No. You feed it the most real-world data as possible, structured as well as unstructured. It will find the structured out of the unstructured. So you want to make it as resilient as possible. And it depends on what type of artificial intelligence that you want to use. Do you want to use reasoning? So do you want to use agentic AI? Do you want to use large language models to go into agentic AI? Or do you want to use predictive AI? Sort of depends on the contextual application.
So if I am asking you a question on behalf of Dr. Vivek Agarwal, what is it that ACOS can do to join hands with you in the field of artificial intelligence and cardio-oncology?
Let's join hands and create the data first. Let's get the data first. The AI is the simple thing. And what I would suggest, if we go ahead with this, we need a good amount of clinical data, cardiac clinical data, oncological clinical data, and a good amount of biological data. Only then, with the combination of clinical and biological data, evolution of the cancer, evolution of the cardiac toxicity, that's where, that's where we would create a good amount of intelligence. I think Arjun sitting over there, he would be able to tell more about the G-Core registry that we have for big data. So one of our colleagues as well, Ami Banerjee out of UCL, works on big data. We've created in Health Data Research UK a huge amount of clinical data set. The limitation is it's not connected to biology. That's what we need. Multimodality is what we need. 360-degree picture is what we need. The AI is easy.
Okay. Got it, Vivek. Thank you very much. My panelists, it was wonderful looking at your interactions and your insights into this very difficult and nascent subject. And I hope that we can learn even more in the future. Thank you very much.
Thank you all the panelists, and thank you audience for listening. No one sleeping in such a complex topic. Everybody is contributing with the data.